like to thank our sponsors, BioLens Incorporated, for sponsoring this webinar series. BioLens are custom soft contact lens manufacturers, and they also manufacture custom scleral lenses and rigid gas permeable contact lenses, autokeratology lenses as well. Today we'll be talking about the use of atropine for myopia management. I'm a speaker for BioLens Incorporated, and I head the cornea contact lens department of the Lens Ophthalmics Eye Center in Nigeria. We've been talking a lot about myopia this week, so we already know what myopia is and what the risk factors are. We know that by the year 2050, it's projected half the world's population will develop myopia. And in Africa, we know that the current prevalence of myopia in school-age children is put at about 4.7%. And it's estimated that that would rise to about 17% by the year 2050. And what's worrisome is about 500 million people are estimated to have high myopia, and we know that high myopia can be associated with complications that can lead to permanent visual impairment. Now, atropine is an antimuscarinic agent, which we're going to be talking about today. What it does is it prevents acetylcholine from stimulating the muscarinic receptors, thereby inhibiting the effect of acetylcholine in the eyes. Now, what that would cause is mydriasis, which is dilation of the pupils, and cycloplegia. We know that it has other clinical uses in terms of pain management, management of ciliary spasm or ciliary block. The mechanism of action is not fully understood when it comes to myopia management. Now, initially, it was thought that this mechanism was due to accommodation, but we now know that that's unlikely because accommodation alone or relaxing accommodation alone does not account for the myopia management effect in terms of axial length control and choroidal thickening that we see. We also know that there's an increase in choroidal thickness when atropine is used due to release of dopamine. And dopamine we know has been linked to axial length control or axial eye length growth. Um, Inhibiting the effect of the glycosaminoglycans on the sclera is another possibility of mechanism of action of atropine. And this would also tune into axial length control as well. And the sclera also has muscarinic receptors, which atropine may also be inhibiting. And that would prevent the formation of scleral fibroblasts. Now, if you do not have fibroblasts forming on the sclera cannot grow or expand. If the sclera does not grow or expand, the axial length does not increase. So it is possible that atropine works for myopia management through one of these means, or it's also possible that it works through a combination of any of these mechanisms mentioned. Now, the very first papers talking about atropine for myopia management dates back to the 60s, the 1960s. Bedrosian et al. In 1966 actually first described the use of atropine for myopia management. So this is not something that's really new. But what they found was that despite it did have myopia control effect, it did not help in preventing with pathological myopia. This was the conclusion that they came to at the time. Fast forward to 1989, Yan et al. Conducted the first randomized controlled trial using atropine for myopia management. And from that study, it did show that atropine, in the atropine group, myopia progressed by minus 0.2%, 2 diopters, compared minus 0.2 diopters compared to the cyclopentolate group, where myopia progressed by minus 0.57 diopters, and compared to the saline group, where myopia progressed by approximately 1 diopter. So we can see from 1989, we had the first evidence for atropine for myopia control use from a randomized control trial. Now, this is another very interesting study that was done back in 1975 and published in British Journal of Ophthalmology. Now, what this study showed was that, or the conclusion that this study came to, which I'll just read, is These results suggest that myopia can be arrested in 50% of cases at the stage at which they present in a Caucasian population. Even in the cases in which arrest has not been achieved, the increase in myopia has been less than in the control group. This means that many have been partially arrested. So this study was pointing to the fact that, and if you actually read the study, the design is almost similar to what you would expect today. And it makes you wonder why um, we've had evidence since 60s, 70s, the 80s, yet it was not mainstream clinical practice. Of course, they were using 1% atropine, but from this study, you see that atropine can be used to either fully arrest myopia progression or partially arrest the progression. Now, fast forward to the current landmark clinical trials that we have. We have the atropine for treatment of childhood myopia study. This was published first in 2006. So what this study had done was they took a group of children, put them on 1% atropine, and after 2 years, measured for myopia progression and axial length change. And it was shown that myopia progression was controlled by about 1 diopter. In the control group, we had that myopia progress by about 1 diopter and axial length increased by about approximately 0.4 millimeters after 2 years. Meanwhile, in the atropine group, myopia progressed by about 0.28 diopters compared to about 1 diopter in the control group, and axial length changed by 0.02 millimeters compared to 0.4 millimeters. So what that shows is very strong myopia control in terms of spherical equivalent refraction and axial length. However, there were side effects. As we would expect from using 1% atropine, there was glare and there was decreased near vision. Now, after the ATOM-1 study was published, which showed um, unequivocal evidence for using 1% atropine for myopia control, the ATOM-2 study then looked at lower concentrations of atropine to see which concentration would give good efficacy in terms of myopia management and less side effects. Now, they tested 0.5%, 0.1%, 0.01% doses. And what it found was that after 2 years, the mean progression was about 0.3 diopters in the 0.5% group, approximately 4 diopters, 0.4 diopters rather, in the 0.1% group. In the 0.01% group, it approximately progressed by 0.5 diopters. So we see that there is a very small increase in myopia progression as the dose goes down. However, clinically, we may not be able to distinguish between minus 0.3 or minus 0.5 diopters, but we see that efficacy is higher with higher concentrations. Now, the mean axial length increase was also similar. We see from the highest end of the spectrum, axial length increasing by 0.41 millimeters in the 0.01% atropine group and increasing by about 0.27 millimeters in the 0.5% group. Now, the most common adverse event reported in the ATOM-2 study was allergic conjunctivitis and dermatitis, which was more common in the 0.1% and 0.5% atropine dose, but not in the 0.01% atropine group. So what this study birthed was a group of practitioners and a belief at the time that 0.01 was the optimal concentration because it did give clinically significant myopia control and also very limited side effects compared to other concentrations. Then the LAMP study came. So the LAMP study is the low concentration atropine for myopia progression study. Now, this study was published in Ophthalmology Journal in 2019. And after the first year of the study, the results showed unequivocally that using 0.05% gave the better myopia control compared to using the 0.01% that was previously thought to be the standard. Because after comparison with the placebo group, we see that axial length change in the 0.01% group was about 0.36 millimeters. And in the placebo group, we see an axial length increase of about 0.41 millimeters. So what this means is if you're looking in terms of axial length change, we don't see much of a difference between using 0.01% versus placebo. So in the long term, 0.01% may not be the ideal thing, and that's why we've switched to using the 0.05% concentration as standard. However, some adverse events were also reported. The amplitude of accommodation was noted to decrease by approximately 2 diopters in the 0.05% group and lesser magnitude in the lower concentration. And pupil size also increased by about 1 millimeters, but the visual acuity and quality of life remained the same. Just give me a minute. Okay. So, after the first LAMP study, there was the LAMP2 trial. Now, what the LAMP2 trial was, what it tried to achieve was to look at, excuse me, what the LAMP2 trial tried to achieve was to look at longer term um, use of low concentration atropine in order to prevent the incidence of myopia or the occurrence of myopia. Now, the 2-year cumulative incidence of myopia was about 28% in those who use 0.05% atropine, compared to placebo, which was about 53%. And then the low concentration of 0.01% gave the incidence of myopia in that group was about 45.9%. So we see that in terms of trying to prevent myopia from becoming from progressing, or the onset of myopia in children, 0.05% atropine still was very useful. Of course, photophobia was the most common adverse events reported in that study. Now, the LAMP study did go to a phase 3 portion where a washout was done to look at rebound effect. Now, continued atropine for myopia management seemed to give better myopia control in the long run. Well, looking at other concentrations in terms of 0.05 and 0.01%, 0.05% still remained the better option for controlling myopia over 3 years. And the differences in rebound effects were small across all the concentrations studied, but obviously higher concentrations of atropine was associated with more rebound effects compared to lower concentrations. Now, other things that were looked at was stopping atropine at an older age and using a lower concentration was associated with using what was associated with lower rebound effects as well. Then there was this other study that looked at the impact of atropine on iris color and ethnicity. We've said in this group several times that when we use atropine for myopia control, we mostly base that of studies designed in non-African population. We know that most of these studies are done in Caucasian or Asian populations. None has been done in African populations, so we just assume that atropine would work here as well. However, this study, which was done in Europe, actually shed light on this topic. What it showed was that between whites and non-whites, after 2 years of following up with use of 0.01% atropine, it was evident that the effect of myopia control or the effect of axial length control from using 0.01% atropine was not the same. Individuals with lighter iris colors experienced better axial length control compared to those with darker iris colors. Now, it doesn't mean that if you do not have access to compounding lower concentration atropine, you can't still use the 1% atropine for myopia control. You just need to keep in mind the rebound effects. Now, this study, which was published in Pediatric Ophthalmology quite recently, looked at the efficacy of dosing 1% atropine weekly for myopia control in Chinese children. And what it showed was that weekly use of 1% atropine resulted in about 0.2 millimeters of axial length elongation after the second year, which is quite good. I mean, a change in 0.2 millimeters after 2 years follows the physiologic eye growth that would be expected when looking at growth curves. Longer lasting effects was seen in older children who had lower myopia. So this might be something to also consider for atropine use in places where compounding pharmacies are not available. It's also been documented that even when atropine is compounded, it may not be the exact formulation of what you may have requested that comes up in the bottle. So this might be something to keep in mind, and this study shed light on that. Now, there have been other pharmaceutical agents that have been studied for myopia management as well, not just atropine. However, these have lower efficacy or more side effects and do not warrant further studies. They include pyrazipine, scopolamine, tropicamide, beta blockers, epinephrine, and methylxanthine. Um, from the studies we've looked at, we see that obviously 0.05% is currently standard of care. However, a lower concentration like 0.01% will have less side effects compared to 0.05%. But there are also studies that look at using 0.01% atropine in combination with other treatments like orthokeratology or center distance multifocal contact lenses. And in the clinical setting, it is very common to prescribe low concentration atropine with a progressive addition lens or a bifocal with a transition tint just to ensure that you're taking care of glare and the minimal cycloplegia that may occur. Some of the pearls that I would advise would be having a good compounding pharmacist to help compound the low concentration atropine. We see that from the study, it is recommended to use atropine for about 3 years and do not stop it suddenly because when you're using a higher concentration, there's a higher risk of rebound effect. So you want to taper that atropine off. Rebound effect is not the same thing as physiologic change that we would expect to see in axial length growth. So what that means is if atropine is stopped and the axial length is growing at what will be considered physiologic rate, 0.2 millimeters or less per year, that's normal. That's not rebound effect. So rebound effect will be axial length or spherical equivalent refraction increasing at a rate equal to what it was before myopia management was started or higher than that rate. So that's important that you note. It's important to measure axial length when using atropine and also choroidal thickness. If you can, and you have an OCT at your disposal, this is something that you can easily measure and you would notice an increase in subfoveal choroidal thickness with the institution of atropine. You've always wondered when it's time to stop myopia management, and this we would take from the correction of myopia evaluation trial. We know that 48% of individuals with myopia stabilize by the age of 15, 77% stabilized by the age of 18, 90% stabilized by 21, and 96% stabilized by 24. Now, if you flip that statistic, what it would mean would be 52% of individuals are still progressing by the time they are 15 years of age, 23% are still progressing by the time they are 18, 10% of adults are still progressing by the time they are 21, and 4% will still be progressing by the time they are 24. So adult myopia progression is a thing, but we see that myopia progression tends to slow after 18 years. So you might consider slowing down or stopping the myopia management tool being used by the age of 18. Thank you very much for listening. If you have questions, contributions, you can leave them in the comment section and they'll be taken after they'll be taken and answered. As always, the recordings for each day will be available on the iAfrica Media page. Thank you very much.